further treatment options. So that's focal epilepsy. And then the American Academy of Neurology, they periodically produce clinical guidelines. And in this one from 2013, it's a little bit dated, they provided evidence to guide clinicians in terms of when to use the vagus nerve stimulator in a variety of other diagnoses. So, Lennox-Gastaut syndrome is one of the more severe types of epilepsies that tend to start in childhood, although we can have adults who acquire it later on in life. But these patients tend to have very difficult to control seizures, multiple seizure types, and so the vagus nerve stimulator can be very helpful for these situations. So these are indications that are not necessarily in the FDA, but we use them clinically. And then in children with medication-resistant, both focal and generalized epilepsies. And I should just clarify the terminology. Sometimes I use focal, sometimes I use partial, and that's just a reflection of how the nomenclature has changed over the years. They mean the same thing. So focal is partial, and then generalized, of course, is, could be a genetic, could be idiopathic. So children with medically refractory focal or generalized epilepsy who are not considered to be good surgical candidates or who have tried surgery and failed. So we always like to offer surgery first to these patients, especially if we think they are a good candidate, because we tend to get better, of course, better outcomes. But if someone, let's say, doesn't want surgery, or we think that surgery wouldn't necessarily be appropriate or helpful, that might be a good option for these patients. And, the AAN also recognizes that patients with adult patients with epilepsy and depression, in these folks, mood improvement may be an additional benefit to consider. So when you're thinking about treating concurrent or concomitant medical conditions, this would be something that we would keep in the back of our minds. So what does this look like? So I have a little chart here that's called treatment progression. I don't know if you can see my cursor here. So when someone first gets diagnosed with epilepsy, we would often start a first medication. And of those patients in general, according to this study in JAMA Neurology, about 46% of patients become controlled. And if you don't have good seizure control, then we would go on to try a second medication. It might be something we try singly by itself, or maybe in combination with the first one if it looks like the patient got improvement, but not completely. So an additional 12% of those patients may see complete seizure control. And then after that, remember I said that the refractory nature of seizures is typically defined by failure of two different medications. Then when we try the third medication, you can see that the success rate really comes down pretty significantly. So for additional trials of seizure medication, only an additional 6% of patients become controlled. So if you add up all these numbers, it's about 75% of patients can be controlled by seizure medications. And so that means the other 25% may not be controlled. And this is when we consider other options. And the other options are always are add-on and never I should say never, but most often not a complete replacement of seizure treatments, or seizure medication treatments. So and so in the clinical world that we operate in, I said that we would start with the first one, and if that doesn't work, we would try the second one. And I want to point out that when someone is meeting criteria for being medically refractory, we always want to offer a treatment option that we would consider to be highly effective. So the third drug is likely going to only be effective in 6% of the time. And so we ask ourselves, would surgery be an option? And when we say surgery, we sometimes mean resection or neuromodulation these days. It does not have to be removal of the brain tissue all the time. So, for example, for patients with a genetic generalized epilepsy syndrome, there's nothing to resect. We can only do neuromodulation. So we kind of lump this all together as surgery, and the typical scenario would be that we put all this information together. We talk to our patients in the clinic and say, would you be interested in some of these other treatment options? And then we do some additional testing. When we put all that together, we would present the whole case in front of our entire epilepsy group at Beth Israel. And we discuss what are the various surgical treatment options. And sometimes patients do proceed with surgery a lot of the time. And if they become completely resolved, in meaning that the seizures are controlled, but the epilepsy itself, it's in the background, then we have a very good clinical outcome. But nothing's 100%. So in a small subset of those patients, even in whom we thought surgery would be a good option, if their seizures are not controlled, then we would offer other treatments. Now they put dietary, this is a slide that Livanova prepared. They put dietary therapy here. I don't necessarily think it belongs in this step. It could be much earlier on. But you can see that of the neuromodulatory devices, there is vagus nerve stimulation, there is deep brain stimulation, and there is responsive neurostimulation. So since we're talking about VNS tonight, I'll just kind of focus on this, but just know that there are these other options. And for some patients who, let's say, do not want to try anything that's invasive, we would continue to work on the various options because there are, as you know, various, quite a lot of different seizure medication options out there. So we would continue to try. We would not necessarily give up in that scenario. And so this is just a kind of a busy slide. This just shows what you already know, that in a lot of our patients who have seizures that are difficult to control, it's not surprising to see that they may have concurrent depressive symptoms. It may be as a reaction to the epilepsy itself, or it could be that they may coexist, that depression is a common occurrence even in the general population and may coexist with epilepsy. And it's been shown that in patients with epilepsy and depression, that their quality of life may suffer as a result. But if they have VNS, they seem to do a little bit better than people who don't have VNS, and certainly in the scores that they use to measure sort of quality of life, patients seem to do a little bit better. And so we ask ourselves, how does this device actually work? It's a little complicated. It hasn't been, the exact sort of mechanism of action is not definitive, but there are many different proposed pathways that the vagus nerve can stimulate and affect how the brain functions. So this is kind of a more of a simplified version of what our current understanding is. So the nerve that comes out of the central nervous system in the brainstem actually comes in the neck, and it affects your heart function, your gastrointestinal function. And so this nerve can bring signal down to your vital organs. It also receives signal back up, and so the brain is getting feedback. And so what the stimulator does is it utilizes the pathway that inputs data into the brain. So when we stimulate, it does have a function both ways, but we think that the afferent, or the input into the brain, is what gives us the over the long term, seizure response. So the vagus, this is kind of a little diagram here. The vagus nerve brings information into the brainstem. And there's what we call a network. So these nuclei in the brainstem have lots of connections with the thalamus, the hypothalamus, and you don't need to know the term, but the nucleus tractus solitarius is specifically part of this vagus nerve projection. And when we activate this pathway, it actually stimulates the inhibitory mechanisms that's intrinsic in the brain, and it amps up the inhibition and it dampens excitation, and excitation is typically mediated by glutamate. And also what it does is over the long term seems to modulate norepinephrine and serotonin through additional nuclei that are called locus coeruleus, dorsal raphe nuclei. And so this is sort of the bundle that we think is responsible for the long-term changes that we see in the brain that ultimately reduce seizure frequency. So I kind of said all that a little bit. So GABA, I just want to say that GABA is something that you'll probably hear about because that is the main neurotransmitter in the brain that's inhibitory, that dampens too much activity. And we want to increase the inhibitory pathways, and we want to dampen or inhibit the release of glutamate, which is overly, which causes or results in overexcitation. So we think of seizures as a delicate balance between inhibition and excitation. So we want to try to restore the balance through the stimulation of the nucleus of the solitary tract. And what ultimately it does is through the connections of all these nuclei, through the mechanisms of the different neurotransmitters, overall, we see inhibition or dampening of cortical activity. And so that is something that we propose is helpful in reducing seizures overall. And when we try to look on the EEG, it's not something that's visible to us through just gross inspection, but with advanced analytic techniques through spectral array and through imaging, we can see that over time there are long-term changes. So initially it was found some kind of the efficacy of the vagus nerve stimulator was tested in animal models, different animal models of seizures. And what they saw, this is a recording in cats. What you see here is a lot of activity. The brain cells are firing away during a seizure. And when they do the stimulation with this little arrow here, you can see sort of everything kind of quieted down. So that's how they were able to show in the animal model that it would be helpful with an acute stimulation. But what we know these days is that the vagus nerve is really through long-term modulation and not necessarily through the acute stimulation, like almost like a cardiac defibrillator. And so what the device looks like, it's like a little metal can that sits in the left anterior chest. It does have little wires, and this is a nerve that I was talking about. This is the vagus nerve that comes out of the brainstem, and this little stimulator has wires that wraps around the nerve, and uh, and as I said, this nerve has connections to the brain and has connections to the heart and the GI tract, the gastrointestinal tract. But through the input through into the brain, ultimately, we're trying to desynchronize. When seizures happen, that's when neurons are firing all together, that's excessive. And so it dampens the synchronization. It decreases spikes. Spikes are what we see on the EEG, that's a marker of seizures. And then it normalizes the inhibitory pathways. In seizures over time, the inhibition is not as effective, so we want to try to normalize the natural inhibitory pathways in the brain. So the first in human trials began in the early 90s. There were two pivotal trials that are called randomized controlled trials, and then ultimately that led to the approval of the device in 1997. I think this is going to bore you. This is just to show the study setup. So they did randomization, which means that people didn't know whether they were in the treatment arm or in the control arm. And so everybody got some sort of stimulation. And then they evaluated patients after a period of 12 weeks, and they found that patients that were assigned or randomly assigned to the high stimulation group had a 50% reduction. At least a third of them had a 50% reduction at 12 weeks. Now, 12 weeks is a really short period of time. That's only 3 months. And so that might be, that would explain sort of the lower percentage of patients that responded compared to the control group or the sham group. Even though it's low stimulation, it was no stimulation. So you're still going to see some response rate even in the control group. And then they followed that up with a longer, bigger study in the EO5. And they also did a high dose group and a low dose group, kind of very similar. In the high dose group, they found about a 30% reduction in total seizure frequency compared to 15 in the low dose group. So these were the very, very early studies. And then in subsequent studies, they were able to follow patients for a little bit longer. In this study, this was a 1-year follow-up at least, and they saw that of the people that had a 50% reduction in their seizure frequency, this was about 60%. And then in people who had 80% reduction in their seizure frequency, this was about 40%. So you can see that over time, the body is adjusting and accommodating to the effects of the stimulation, and more people are joining the group of responders. And now this is even a longer follow-up of 36 months. Again, this is a multi-center study, but this is an open label, not a randomized controlled trial. So patients who they knew who were getting the real stimulation. So they just followed these patients, about over 362 patients, both adults and patients, and they had really good follow-up rate. Over 90% of the patients they were able to account for at the end of the 3 years. And they found that there was a median change in seizure frequency of about 66%. So with time, with stimulation, with optimization of the stimulation parameters, we were able to get more mileage of the stimulation. And this is a much smaller study now, over 10 years. So it's hard to do studies of patients for such a long period of time. So that's why you see that the N is much smaller, only 65 patients that they were able to follow. And so at 6 months, you could see that there was maybe a quarter of the patients were able to see a 50% response, 50% reduction. But by the time you got to 10 years, you got up to 80%. And then there's some variability because it's a small group of patients. You might even get up to 88%. So basically the trend is that, over long-term stimulation, people tend to get more benefit with time. And I'm not going to scare you with this one, but I wanted to make the point that the vagus nerve has been studied in by many different groups, involving, large numbers of patients or small numbers of patients. But what we generally see is that when we follow patients, this is on the y-axis here on the left is number of months. Over time, we see the trend up, which means that more people respond to the long-term treatment effects. That's all you need to take away from that. And this is a quality of life measure that they did. They have a little line here. So the line, anything that's to the right of the line is something that's considered clinically meaningful. And in terms of the quality of life measures, what they saw that was meaningful was social function and cognitive function. And there's a hint that seizure worry was also much better when patients had VNS over time. The emotional well-being, I suppose, could be a little bit more variable. And so the results were not so significant at 3 months, but you can see that after 12 months, so pretty much everything was much improved. So these were the 4 measures that were notable in this particular study. So in the diagram that I showed you earlier, this is the vagus nerve stimulator. This is what it looks like up close. It's kind of light. It's a little, I would say just a little bit bigger than a quarter. And the Sentiva 1000 is the latest model that we are implanting in our patients now. And it's a day surgery. It goes into the chest. It just lives under the skin. It's not in the muscle. It's not like a heart defibrillator at all. You'll feel it. If you put your hand over the skin, you'll kind of feel the canister. But the nice thing is that other people don't really see it. There is a little bit of a scar in the chest, though, when the surgeon puts it in. But you don't have to stay in the hospital. They implant it right away, and then they'll give you instructions to go home, and you'll have to be careful not to lift anything heavy for a period of time so that the wound can heal. And then once it's all healed, we can start the programming process. And then here are some more, details about it. It's made of titanium. There's a lithium battery in there. The lead wires anchor on the vagus nerve here. And even though you do have this little metal device, we can still do an MRI if we're further away from the device. And we often are still able to do a brain MRI, including a very high resolution study. The 3 Tesla study is what we use most often in our epilepsy clinic. And then the lower resolution 1.5 Tesla, of course, that's both are feasible. And they usually choose the left side because that has a lesser effect on the heart. I mentioned earlier that the vagus nerve controls your vital organs, especially your heart rate, actually. And it is the thing that calms you down. So the right-sided vagus nerve has a greater effect on your heart rate control. The left side has a lesser effect, so that's why it's implanted on the left side. Occasionally, we do implant it on the right. If somebody has a, let's say, maybe they had another device on the left side and there's just not enough space because we have to really space out the devices. It could be implanted on the right side as well. So you'll see 2 incisions, one in the chest where the battery and casing sits, and then there's one little nick in the neck, and that's where the wire is kind of tethered and anchored onto the nerve itself. And so nothing is exposed to the outside and everything is on the inside. So once it's healed up nicely, you can shower and you can wear summer clothing. It's not going to be very obvious to people. And once it's implanted, this is the kind of thing that we do in the clinic or in the hospital. We have a little wand that you place over the generator and it talks to the device. So, and then we use a tablet to see what the settings are. And this is what tells us, how much battery life is remaining, is the device functioning well, and what are the settings? What are the stimulation parameters? This is and this is what we do in the clinic. I like this photo because this is exactly what I did today in the clinic. I usually or the patient could hold the little wand over their device, and I can see on the little tablet, and I can program using the tablet. I can change the settings that way. And then the patients generally have a little magnet. So how we turn on and off the device can be easily done through a magnet that you can either wear around your wrist or you can wear it around your belt. I've seen some patients kind of wear it around their belt. And when you swipe this little magnet over the device, just like so, you swipe it, kind of up and down, kind of slowly. Oops, I'm sorry. You're able to turn it on. And I'll explain the settings, but this gives you added control of the device. And if for some reason you wanted to temporarily stop it from stimulating the vagus nerve, you just kind of tape it over the device with a piece of tape, and that temporarily stops the stimulations. So what are the settings? Well, the device has three different kinds of stimulations. It's always going on and off, and that's what we call the normal mode. So, it the typical setting would be it stimulates for 30 seconds every 5 minutes. So it's going on and off, 24/7. And that is amenable to change in terms of, how frequently we want it to go off, how long we want to go off. Every one of these parameters is customizable. And then this is the magnet mode. This is the what I call kind of on-demand stimulation. So if you feel an aura coming on, or if the family member sees that the seizure is happening, you can actually give an extra stimulation in addition to the everyday, preset parameters. We can give an extra one. And the reason we give an extra one is that sometimes that could help patients actually abort the seizure, meaning stop it, or we can make it shorter. Sometimes it can be helpful to prevent the seizure from spreading to other parts and becoming a more significant seizure. And sometimes patients tell us that when they use the magnet, they come out of the seizure a little faster. So the post-seizure effects are shorter. And then this is the newest mode. It's called auto stim or automatic stimulation. And this is based on the fact that we see sometimes the heart rate goes up even before the seizure starts. And when I say before the seizure starts, that just means what I can see on the EEG on the scalp. So it's interesting. A large percent of seizures can affect heart rate, and sometimes that heart rate changes even before the brain waves change from the scalp. And so we're taking advantage of that lead time with a heart rate. And so this little sensor detects your heart rate. So if your heart rate starts to go up really fast, the device thinks that this could be the start of a seizure, and it could deliver an extra stimulation without you having to activate it with your own magnet. So let's say that if you don't have an aura, like you don't have a warning, or if there's nobody else around, well, if your heart rate goes up, this device can give you that extra control without you being part of that. So that's been helpful. Um, this is just an example. You don't have to know this, but this is just an example of what the settings might look like. So I mentioned that the standard is 30-second stimulation occurring every 5 minutes. That's 5 minutes off. You could set it more frequently. So it could be 30 seconds on for every 3 minutes. And then sometimes we go into rapid cycling. So it could be on for a shorter period of time, but it's going on and off, on and off, on and off really frequently. And the highest that I've listed here is 44%. So that means 40%, 44% of the time, the device is stimulating. And the other 54% of the time, it's in between stimulations. And we found that when we rapid cycle, when patients have seizures that are really hard to control, and when we rapid cycle, meaning we deliver more stimulations, we get better seizure control that way. The on-demand, which is using the magnet, this is typically given either by the patient themselves or by somebody who's there with them. It could be a family member, a friend, or somebody in the school or in the workplace who knows the patient. So this gives us extra control. And in some of the older studies by Boone and Morris, they were able to show that maybe about half to about 2/3 of the patients feel that the on-demand stimulation can help them either by stopping the seizure or shortening the seizure or helping them to recover faster after a seizure. And the earlier that they activate their VNS, the more effective it is. Meaning that if the seizure is very far in and it seems like things are long gone, when you try to stimulate the vagus nerve, is not as effective compared to when you get it, when you try to nip it in the bud in the very beginning. Unfortunately, it doesn't work for everyone, but if it works for people that do have that prior warning, it's super helpful. And then the heart rate piece of it is, as I mentioned, seizures from the brain, the cortical aspect of the brain can stimulate the heart and actually cause the heart rate to go up really fast within seconds. Within 2 to 3 seconds, your heart rate can go from a baseline of 70 up to 120. And so that's a very unique signature of seizures. And it's not something that you can necessarily attain just by exercise. Like if you're climbing stairs, generally it takes time for the body to adjust and the heart rate to go up. But for seizures, not so. Because the stimulation, because the firing is so fast within the seizure, we can see that heart rate go up within seconds. And so the device, luckily, it sits very near the heart, can easily detect heart rate, and utilizes that signature. And we can set the device to go up in the beginning. So there are different ways of setting up the device to sense the heart rate. So in the most sensitive case, if your heart rate goes up by 20%, we can ask the device to give you an extra stimulation. Some people don't like that because they're getting a lot of extras. Maybe when they're walking, their heart rate goes up 20% and they get an extra stimulation. So we kind of gauge it based on how the patient is feeling, how active they are. And in people who are active, we might have to set it on the least sensitive, meaning that the heart rate goes up, has to go up by a lot. The heart rate has to go up by 70% before the VNS goes off to give an extra stimulation. But it's helpful to have the varying customization so that we can tailor it to each person's needs. So this is a kind of just showing, you know, the background heart rate is over here. And if you go up by a little bit, well, then the VNS sees it and it delivers a stim. But in the least sensitive setting, the heart rate has to go all the way up here with a clear spike before the VNS goes off. And now the newer model also has some additional features. So the day settings and the night settings could be a little different. So and that's been really helpful. So for example, if somebody has a lot of seizures at night, but really none during the day, well, we would try to maximize the stimulation at night and minimize the stimulation during the day. Or maybe the person is, having a lot of meetings during the day and they do find that they have a little bit of hoarseness. So we can try to maybe decrease the settings during the day to allow for speech and talk and meetings and so on, and then try to maximize what we can get out of that nighttime period when someone's asleep and they don't feel it. And then they also have this thing called the scheduled programming. And that's helpful for people who are a little bit further away from our medical center. So typically what happens is somebody who needs the settings increased over time, they have to come back to us so that we could use the wand and the tablet to program it. Well, in this particular setting, you could set it up so that it goes up automatically. You could set it, say, every 2 weeks or every 3 weeks or every week, I want the output current to go up by 0.125 milliamps. So you could program it so that the patient who lives far away doesn't have to come back every week for the programming. They could maybe come back every 4 to 6 weeks. It doesn't solve all the problems, obviously, because if you go up and the patient doesn't tolerate it, they still have to come back so that we could change the settings. But it is helpful if they're doing well, or if you have a very slow titration, they don't have to come back as often. There are some instances where we don't recommend it. The vagus nerve stimulator, I would say, in my view of neuromodulation of devices, is probably the least invasive and I would say best tolerated. There are some cases where you might not want to recommend it. So people who don't have a vagus nerve because they had the nerve cut for some other medical reason. So in the old days, for people with really bad gastric ulcers, they used to do a vagotomy. And then for people who have scar tissue or damage in that region, we definitely don't have the luxury of being able to use that device. And for some time, for anybody who has a kind of, it's not an absolute contraindication, but for people who actually have a heart rhythm abnormality, what we call a prolonged QT syndrome. I don't have it on this slide, but I want to mention it here, is that, those are people who have really, really slow heart rate. And the vagus nerve actually dampens everything down. It can slow down your heart rate. So we just don't want to exacerbate somebody who already has a baseline slow heart rate. So we want to make sure that before you get the stimulator in, everything is good. Your heart rate is good. You've got good clearance. And if there's any issue at all, we might ask you to go see a cardiologist before you come. Um, and then precautions. So not a contraindication, but precaution. So typically, if you have the vagus nerve stimulator put in, if you have to have a cardiac ultrasound, that's not a problem. But when you go into surgery and they use other electrical devices, that's when you do have to be careful. So anything that uses strong magnet, like if you get an MRI, we do have to turn off the device. If they're using cautery or ablation in surgery that's near the area of the device, that's when we have to check in and make sure that there's not going to be any interactions that could cause the device to malfunction. So typically what we do is we turn off the vagus nerve stimulator in those cases. And then other precautions, pregnancy is always a precaution for everything. Um, it has never come up in my practice. Other devices, it's not a contraindication for people who need their heart rhythm paced. So cardiac pacemakers. In fact, this morning I just had a gentleman who had a cardiac pacemaker on one side and the vagus nerve stimulator on the other side, and it has helped him a lot. Of course, both devices. But they do have to be, 10 centimeters apart. So on a theoretical basis, they don't interfere with each other. And then other precautions would be, I'll go into that in a little bit further detail, but if it doesn't feel good or if it's causing you intolerable side effects, then that might not be a good option for you. But in general, it's really well tolerated. The risks are very, very minimal, but every device, every procedure does have a risk. So typically what we would say is the risk of the device is infection. Anytime you do a procedure, there's a risk for infection. And if the infection actually involves the canister itself, we do have to take it out. And that has happened rarely. Sometimes patients are nervous and start picking at their wound, and that seems to introduce bacteria, or sometimes for no reason, there may be bacteria that have entered into the bloodstream and seems to have settled there. So in those cases, we have no choice but to take it out, allow the infection to clear before we consider whether we want to put it back. Extremely rare, there may be vocal cord paralysis, and that's because the vagus nerve controls a lot of things. It controls your swallowing, it controls your vocal cord, your speech, and that's why sometimes when we stimulate the vagus nerve, people might sound a little hoarse. And laryngospasm, that's kind of just saying that the throat can feel tight and the muscles contract, extremely rare. These are kind of extremely rare. This bradyarrhythmia, it means your heart rate slows down. And I alluded to it earlier. When the sympathetic nervous system is active, your heart rate goes up. But when the vagus nerve, part of the parasympathetic system, is activated, you calm down, your heart rate goes down, your breathing slows, everything. You're in a more Zen mode. But if that's too much, then your heart rate slows down too much. If your heart rate goes below 40, that's not good. And we want to avoid those situations. I mentioned asystole. Sometimes when the device is being implanted in the operating room, the heart temporarily stops. And I want to emphasize that's totally temporary, only on the implantation. It always resolves. We've never had people where their heart rate does not come back. One thing to be aware of is that it can cause so much relaxation of the neck muscles and of the larynx is that it sometimes can cause people to have worsening of their sleep apnea. So if there is sleep apnea, it's not a contraindication because we still want the seizure benefits. So, but it does mean that during sleep, the day and night mode, I like to lighten up the stimulation at night so that we can avoid exacerbating the muscles and the breathing, but still take advantage of the daytime benefits. So I mentioned some hoarseness. These are the most common side effects that are listed here. So hoarseness, because the vagus nerve stimulator controls your vocal cord and your neck muscles. It's typically transient. So this is the most common one. In the first year, maybe up to 30% of patients may experience it. But look at this. By the time your body is amazing, it gets adjusted. By year 3, only 2% of people may feel that their voice is hoarse. And this is also something that we can mitigate by changing the settings of the stimulator. So we could use lower settings. We don't have to stimulate for as long. So there are different things we can do to try to minimize the hoarseness. And also just to keep in mind, hoarseness of the voice is not a dangerous side effect. It's kind of more of an annoyance, except if you're in a meeting, you're trying to speak, that might be, that might, interfere. But in general, it's not uncomfortable, and people tolerate a certain degree of hoarseness. The paresthesia is really just means tingling. It could be tingling in the neck, tingling in the throat. It generally goes away. In this study, they had 0%. And currently, of all the patients that I have VNS, they don't tell me about the tingling. In fact, they like to have the tingling because it tells them that the stimulator is working. They're not bothered by it. It also is the vagus nerve mediates the cough reflex. And so when it goes off, sometimes people give a little bit of a throat clearance or a little bit of a cough. It's not persistent. And it also goes down significantly with time. And this is a more of a subjective feeling of shortness of breath. It's not that people are not getting enough oxygen or they can't breathe, but it's a perception of shortness of breath. And that also goes down with time. Um, I'm missing a slide. Anyway, I had a bar graph that actually shows it a little bit better. These are some of the other side effects that I've experienced with over the years. Sometimes people have a little bit of discomfort or even pain. That just means that the stimulation current is a little bit on the high side. We have to just back it down. We don't ever want to see pain in the throat. And sometimes people may have a little trouble swallowing. It's extremely rare. And that also improves with time. That depends on how much we turn up the stimulator. In children, sometimes children have drooling, and really rarely patients have delayed gastric emptying. And why would that be? That's just because the vagus nerve controls your gastrointestinal system, and it calms it down so much that things aren't going down as quickly as we would like. Um, Extremely rare. And and as I mentioned, all of these can potentially diminish over time, and we can change the settings to minimize the disruption of these feelings. What about some advantages? What are the advantages? In my personal experience, I've found it very helpful in cases where we've tried a lot of different medications. We might have tried all of them, and the medications don't work. But this vagus nerve is such a different mechanism that it's helpful for seizure control. And because it's not a medication, it doesn't affect people's thinking. And you're not dealing with all the medication side effects of feeling sleepy, feeling off balance, feeling very tired. So in fact, sometimes people feel like it gives them a little bit of an alerting, or more of a stimulation to be more awake. And over time, we saw in the graphs, in the studies that people have done over, the typical counseling I tell people is over the first 2 years, you're going to experience the maximum therapeutic benefit. You're still going to get some benefit over time, but it's not going to be as dramatic as the first 2 years. And that degree of seizure control and benefit actually is enduring. So with time, it's not like it goes away and things kind of wear off. I should say never. I never say never, but rarely do I ever see that the VNS loses this effect. it may lose effect when the battery starts to wear down and we have to replace the generator. And then I already mentioned these earlier. Sometimes seizures are shorter and people recover a little faster. And also the sense of control has been really helpful when they can activate it with the magnet. And now with a heart rate sensing aspect of it, you don't even have to have a magnet with you. It could turn on by itself if if um, if the heart rate actually is, if the heart rate increases a feature of the seizure itself. And here, because you have the device in, it's not something that you have to remember to turn on and off. It just does it by itself, and you don't ever forget to turn on the VNS typically. So I mentioned disadvantages because, of course, with everything, um, this is a scar that you might see. The surgeon was very strategic in this case. They kind of buried the scar in the natural folds of the neck, so it's not as noticeable. And so this is what might look like after 3 months. You can see it, but it's not all that obvious. Um, Currently, we do have to replace the battery every 7 to 10 years. It's done as a day procedure. It's pretty quick. And what they're replacing is not the wire in the neck, but the generator that sits in the chest. And it's done by general anesthesia. People recover from it very well. I think eventually they would be able to come up with something, hopefully, that is rechargeable. So that seems to be the advantage of some of the other devices. We do have to be careful because these little components are pretty delicate. So no contact sports. If you fall or something bangs into it, there is still a chance that it might damage the casing or the wires, and the wires are delicate in the neck. And sometimes when people fall or they do something really funky, they could disrupt the wiring. And in those cases, we do have to, repair that. I put cost in here. Uh, the of all the insurances, I've not seen any insurance company not cover it. But of course, the device is a device. It does come with an associated cost, but never out of the patient's own pocket. So, in my view, where does it fit in for therapy? I think that in people who have not responded in terms of medicines after they've tried 2 good doses, and they either don't want surgery or they can't have surgery, I think this is where the VNS would come into play. And I think for people that may even have tried surgery and maybe failed surgery, this would be something to consider. In people who have, multiple seizure foci, so, the seizures coming from the left side of the brain and the right side of the brain, and we can't really, go in and take out all these different areas, the vagus nerve stimulator is helpful. And I would say that in people who have depression or people who have a diagnosis of Lennox-Gastaut, I've found the device to be very helpful as an add-on therapy. It wouldn't replace the seizure medicines, but it would be an additional method or tool in our toolbox to help. Um, and in generalized epilepsies, even though it's not necessarily FDA approved for that indication, we've had lots of patients who have responded. So in general, I would say this is an off-label use of the vagus nerve stimulator. I have to say that our patients have responded very well. And uh, lots of epilepsy specialists you'll see in different centers may recommend the vagus nerve stimulator for people who don't want anything intracranially. Some people are very averse to intracranial procedures, and I think this is a good option. And as I mentioned, it really is not like a medicine that goes through your system. It doesn't interfere with your thinking process.